to our next presenter, that is Dr. Shivani Juneja Bedi, who's the head of clinical pharmacology at Fortis Hospital, Mohali. Welcome, Dr. Shivani.
Thank you, everyone. Greetings to all, and I would like to thank Ruby Hall Clinic and Kaho for giving me this platform to share my thoughts about the audits and committees. So, though there are time constraints, but I'll try to justify a few important aspects of medication audits and the committee associated with the medication safety. So, to begin with, I would like to start with the DTC or the PTC. So, these are the interchangeable words. I mean, drug therapeutic committee or pharmacy and therapeutics committee is being used in different places. So this committee is established to ascertain that a protocol has been laid concerning the use of medical supplies and to ensure that the same is implemented. So the purpose of the PTC is to advise on all medication related issues. So the question comes, who are all the members of PTC? So PTC has people from different domains, clinicians to clinical pharmacists, clinical pharmacologists, microbiologist, AMS champion, store head, pharmacy head, people from HCM, I mean to say the nursing people. So it's a multidisciplinary team who all are involved in hospital functioning with respect to medication. I mean, different aspects of the medications are covered by these teams, so that all in one platform are able to decide on various medication related issues. So the chairperson is usually taken as a clinical person, is a senior physician who chairs this committee, and the convener are clinical pharmacist or the clinical pharmacologist. So what are the scope and functions of this committee? So the first and foremost is the policy development and education. So the committee formulate policies with regard to the evaluation, selection, and therapeutic use of the drugs and related devices. So drugs and devices, what all are to be used in the facility are decided by the PTC committee after the requisitions from various departments has come. So quarterly, most of the times these are the quarterly meetings wherein according to the policies, these things are being considered. The second is the rational use of drugs. So here to serve in an evaluative, educational and advisory capacity to medical staff and organizational administration in all matters pertaining to rational use of drugs and devices both. So this committee plays a critical role here, wherein when some drugs are being used, for example, in the form of audits. For example, we are doing an antimicrobial audit in the hospital and presenting our data in front of the PTC committee. So we look at the various aspects of which are the drugs being used empirically or evidence based, and what are the key steps which are required to be taken up in the hospital with respect to the antimicrobial resistance and looking into the patient safety. The next is to develop a formulary of drugs which is accepted for use in the organization and provide its constant revision based on the objective evaluation of their therapeutic efficacy and safety. So herein what happens, I'm just giving an example, that a formulary of drug, for example, in a hospital is revised every year basis the various drug requests which have come up. The hospital is already having a formulary, but this is a continuous process, and there are various drug requests which come over at a regular interval of time, and which all to be included in the formulary and not is decided by the PTC committee, because the efficacy and the safety of the drug has to be considered, and it's a very vital thing before we introduce any drug. And evidence-based medicine is one which needs emphasis with respect to addition of the drug in the formulary. Next is safe and effective drug therapy, which is cost effective. So I think most of the people who are here must be knowing the concepts of health economics and outcome research, which is an upcoming field, and the pharmacoeconomics concept. So that is also one important thing which is at times neglected and which needs to be known, wherein whenever we are looking for the effective drug therapy, it should be cost effective for the patient also. So this committee ensures that the drug therapy is effective and is not putting an overburden to the patient with respect to the treatment. Then to participate in the quality assurance activities and to monitor and evaluate adverse drug reactions in the hospital, to make appropriate recommendation to prevent their occurrence. So as I've been already talking about the introduction of drugs in the hospital, so whenever we have some new drugs in the hospital, they need to be properly monitored and the ADRs to be evaluated and presented to the PTC or the DTC committee, wherein the decision regarding the addition of those drugs in the hospital formulary are being made. And it's like a check for the drugs which are coming to the hospital and which are given to the patients. So these are the few important functions of the Pharmacy and Therapeutics Committee. So coming on to the audits. So audits play a key role when we are designing our policies and we are laying down various protocols for a hospital for the smooth functioning and I would say a good aspect of patient safety with respect to medication. So the audits can be prescription audits or the medication added audit. So I'll begin with the prescription audit. So what are we doing here in the prescription audit are to monitor, evaluate, and if necessary, suggest modifications in the prescribing practices of medical practitioner. So the prescription audit is conducted by a licensed pharmacist, resident doctor, in-charge nurse, or a physician assistant. So the question here is, are all the pharmacists, all the doctors, all the nurses and physician assistants capable of doing the prescription audits? So I would like to emphasize here, training plays an important role here. All the people mentioned here need to be trained. They should have a sound knowledge of the drugs. They should have a sound knowledge of the audit, because the value can be only added if we know about those things. So the training plays a crucial role. So the doctor who is taking, so I'm not talking about the doctors who are in the system from 20 years. I'm talking about the new doctors who have joined the system because they are just graduates, the resident, the floor doctors. They also need training, because here we train the people, tell them about the various components of the prescription audit, and we need to look at the rationality of the prescription along with the completeness in the form of drug, dose, frequency, and appropriateness, which forms an important part of the prescription audit. So the people who are carrying out the prescription audit should be trained in medication management. So what is reviewed? So this is important. So we need to review the appropriateness of the drug, dose, frequency, and route of administration, therapeutic duplication, allergies or sensitivities, any potentially drug-drug interaction or drug-food interaction, variation from hospital criteria for use. For example, we have some protocols for the critical drugs in the form of high-risk drugs, potassium chloride, insulin, calcium gluconate, and other electrolytes. So the hospital lays down a protocol for the same, and we need to see if there are process compliance there or not. Then to review the patient's weight and other physiological information, because this is very important, and with respect, especially with respect to the vulnerable population, the pediatric and the geriatric population, and especially in the onco patient, wherein the drugs are being given weight-based, and we need to look into the parameters before we go for the audit of this vulnerable population. Then other contraindications and reconciliation. So reconciliation is very important, and this is being one aspect which is WHO is concentrating with various programs here, that reconciliation plays an important role with respect to medication safety, because at this time most of the people are on polypharmacy, and the number of comorbidities when the patient present to the hospital, the number of drugs are already ongoing, and we need to look at what are the previous drugs which are going and what need to be continued in the hospital. So what happens, the reconciliation takes place at 3 places: at the time of admission, at the time of a transition of care, and then at the time of discharge. So when the patient present to the hospital in the emergency, reconciliation happens there. When from emergency to another ICU or ward shifted, the reconciliation takes place. And from our own audits, we have found that there are gaps, especially with regard to transition of care. So this is an important area of attention, wherein we need to have good reconciliation process in our hospital, so that we can look at the right medication practices, because medication for the comorbidities play an important role when we are looking at the good patient outcomes. So these audits, prescription audit can be on inpatients and outpatients. So when we talk about the inpatients, since the patient is with us, we can go for a thorough and elaborated inpatient prescription audit. But there are a few challenges with respect to outpatient OPD prescription audits, because that is, the inpatient audits are mostly prospective, wherein the patient is inside the hospital and we are looking at the various aspects of the prescription audit, various parameters, if they are being taken care of or not. But for outpatient, most of the time it is when the patient has left the hospital, we are getting the outpatient slip of the patient, and we look at the components of the prescription. So few things in the outpatient are challenging, are missed, and especially with respect to antimicrobial prescription, and I would say the antimicrobial stewardship is one of the challenging area with respect to the outpatients. So I'll just share with you that these are like just taken from a paper, though we have a separate our own prescription audit format here. So this is like few of the important checklist things which we look at the OPD prescription audits when we are reviewing the prescriptions in the OPD. So this is one of our own IPD prescription audit form, which is a very elaborative 2-page audit form where we are looking for all the important aspects with respect to prescription component compliance, non-compliance, and the various remarks are being filled, because this is how we are able to identify the areas of improvement and plan our education and training sessions basis our own audits. I request people to mute themselves.
I request all participants to mute, please.
So continuing with the prescription audit, what are the benefits of prescription audit? So I have just tabulated few of them to identify and promote the good practices, improve professional practice and quality standards. So that is very, very important, because once we see our own mistakes, I think that gives us a better learning than looking at the other late protocols. So supports learning and development of staff and organization. As I already said, we find out our own gaps and then plan the learnings accordingly. The education and training is planned accordingly, and that is a continuous process. Then to identify and eliminate poor or deficient practices, promote working with multidisciplinary team. So that's very clear from the fact that a clinician, a nurse, and a pharmacist, they are working as a multidisciplinary team, and the input of everyone matters, because we are in touch with the patient at different points of time. Then to allocate resources, financial or human, to provide better patient care. So we need to find out that to have a better prescriptions wherein which can aid in the better patient outcomes, what all is needed with respect to any whatever institution help is required. Basis all hospital, I think it depends upon the individual hospital and the availabilities of the facilities there. So this is one study I would like to quote here, that wherein prescription audits were done, and it concluded that serial prescription audits and an active feedback definitely improve the prescription behaviors and the therapeutic decision making, and when it is discontinued, it reverses the improvement in the prescription behavior. So that's what I was trying to reiterate, and I would like to reiterate that for better practices, we need to have a continuous process of prescription audits, and active feedback plays an important role, because that is how we are able to plan the way ahead. So coming on to the next audits are the medication error audit. So why are we doing medication audit? Is to identify the medication errors in the hospital and to mitigate these errors to prevent patient harm. So, and I think on this World Patient Safety Day, medication no harm is our primary theme, and this is how we all everywhere in the world are working to combat the medication errors. So this is one medication error audit form. This is what we are using here. I just wanted to share a glimpse with you that herein we are taking the identification of the patient to the area of error, the name of the drug, category of error, employee category, location of the medication error, types of error. So I'll just brief about the types of error after this. So what I wanted to emphasize here is there are a number of things which need to be looked in, because without that incomplete identification of the medication error, it becomes very difficult to find out the area where we need to put emphasis to avoid these medication errors. So anybody from a resident doctor to a staff nurse or a pharmacist or a consultant can would be contributing to the medication errors. So we try and take it to individual stakeholder and try to look into it, because this is a complex process and challenging every day, and an important area wherein the everyday prescription appropriateness review is required and is must, I would say, with the help of the clinical pharmacist. So just a brief about what all kinds of errors are. So it could be a prescription error, which is by the clinician who's writing the prescription. So I would just give you a brief that what common errors we see in the form of the loading doses of at times the antimicrobials are being missed. So this is something I won't say there is they don't know about it. The only thing is that maybe there's a constraint of time and there's a need for a regular updation about the medications, because there is a lot of turnover of medications, new coming, old coming, the brand change happening in the market, and every drug has a different manufacturer recommendation. So we need to be very active, proactive, and searching for the literature of the drug. So regarding the transcription error, so this is mainly here resident doctors, the DNPs and the floor doctors are involved, wherein the prescription which is given by the clinician or the treating consultant is at times not transcribed on the medication administration record, and the drug which is supposed to be given to the patient is missed at times. So there are different categories of transcription error. It could be a missed transcription, it could be a wrong transcription, and to name a few. Then administration error. So this goes in the bucket of the nursing, wherein the administration error can be in the form of a wrong drug, wrong dose, wrong frequency. It could be a missed dose, and so many other categories. So these are the common ones which we see. Then monitoring errors is after the administration, the drug needs to be monitored, where we could be able to identify any adverse drug reactions. So here patient counseling is very important, especially the patients who can cooperate for that, because ICU patients, I know it is a bit challenging, but for the ward patients, if we know we have a sound knowledge, or the nurse has a sound knowledge of the drug, or the pharmacist can also assist here, can always tell. It is not just, see, the patients have become very educated. The patients are educated and they are very alert these days. So there is no harm in telling them that, okay, if you are taking this medication and if you feel like this is something happening to me, please raise an alarm and tell us that, so that we can intervene at right time, because the drugs are not always, we all know that the ADRs are the extended therapeutic effects of the drug. So they are a part of it, and sometimes there are unidentified allergies also, or anaphylaxis, which really need a kind of emphasis on the patient education. And if we involve the patient in reporting of the ADRs, that helps us in combating these adverse drug reaction also. And if there is any modification in medication required, can be done timely without putting the health of the patient at stake. So that was about monitoring error. So the dispensing error basically starts from the inpatient pharmacy, where the wrong drug dose formulation can be dispensed. So the pharmacist in the dispensing must have a sound knowledge of the drug, their formulation, their strengths, their combinations, because the substitutes can also be given sometimes, but this can be only avoided if there is a sound knowledge about the drugs at the time of dispensing. So this was about the different types of error. So this is the NCCMARP medication error index, which I think most of us are using, the category A to category I to categorize the different type of errors. So I'll not go in details. I'm sorry, I have a time constraint. So the category A and B are the potential errors, and the category C to I are the actual errors. So that depends. C goes from I, the form of no harm, to even the patient's death. So medication error resulting in a lot of morbidities and mortalities which are unreported, especially in the developing world. So before I conclude, I would just like to give you some descriptions of the various literature. I mean, something I found in literature, and I think in India we are not what we are doing. We are not publishing it, as one of the speaker has just mentioned. Whatever we are doing, we should try and publish it, so that helps in dispensing the knowledge, and that gives an insight of what is actually happening around and what we need to do. So this is one of the articles which showed that medication audit and feedback by a clinical pharmacist decrease medication error at pediatric ICU. So this is actually the need of the hour, and these feedbacks really help. And I can see with my own team of clinical pharmacists, we have come over and above a number of things wherein we are able to get onto the medication errors by just giving feedback after identifying these errors. The next was another wherein use of an audit with feedback implementation strategy to promote medication error was emphasized by nurses. So as I said, the nurses can be trained, and they are very. I have seen a subset of nurses with our system also who are very good, very active medication nurses, and they have a sound knowledge and they keep a check on the medications, and they are very proactive in giving feedbacks, and that really helps in combating the medication errors. So just a brief about the audits and the committees from my side. So before concluding, I would just like to say no, check and ask, which is the need of the hour for the medication, and all of us are contributing, and we should keep on continuing our good work. Thank you.